I would like to welcome everyone to our POCUS Bites webinar today. My name is Tiffany Claiborne, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is U.S. guided PRP protocols for sports medicine, and our speaker is Dr. Frank Johnson. Dr. Frank Johnson is a primary care sports medicine physician and the founder of Sports Medicine Ultrasound. Excuse me, he has taught more than 55 ultrasound guided injection courses since 2019. And without further ado, I introduce you to Dr. Frank Johnson.
Oh, hey there, Tiffany. I appreciate that. So as soon as you said ready to go, my presentation got a little funny on me. But I've done this maybe I've done webinars maybe 150 times over the past few years, and there's always something new that happens. So I'm just going to hit share, and as far as I can tell, you can see my title, Ultrasound Guided PRP Top 25. You can see that, Tiffany. Give me a thumbs up.
Yep, got you.
Excellent. Okay, thank you. So again, I'm a primary care doc. I started in family medicine and then I moved on to sports medicine. And now I got two full-time jobs, taking care of people in clinic and also running courses. And so webinars are a big part of it. Now, if you do want to play along or read along a little bit, it's not in perfect order, but if you go to sportsmedus.com / PRP webinar, the link's in the chat. You'll be able to find sort of an 80-pager cheat sheet of a lot of the documents that we'll be using today. So we are North America's youngest and most progressive MSK ultrasound training organization. And over the past 5 years, all through the COVID years where everybody had to mask up and everything, I've had the chance to meet so many amazing doctors that come and take our courses that are super eager to learn, and it's been really invigorating. It's a great way for me to get out of clinic, get back to teaching, which is what I truly love. So, and these webinars are fun. Now, there will also be a link to a free PRP course, a paid PRP course, totally up to you if you want to join the free course. It's got a lot of the videos that we'll look at today, a lot of the resources we'll look at today, all in one place, and I'll tell you how to find that later. So, all right. Enough chatter, buddy. Let's have the protocols. I go to a lot of webinars and they're really sort of sometimes slow moving and scientific, and I will do my best to keep you entertained with some really important stuff. So, protocol part number one. Start with more than 10 billion platelets. So I've got people out there who've responded well to PRP injections for their, let's say, knee arthritis. And we just use a little gel tube. We draw 12 milliliters of blood, spin it. We get about 5 milliliters of PRP, which I'm going to argue to you today, hopefully successfully, that is not truly PRP. But the patient has a good clinical response. So I can't argue with that. However, the evidence is mounting that you need to get a lot of platelets out of the patient's arm before you start separating it. Otherwise, you're going to get to your end product and have something that is barely more concentrated than whole blood itself. So the second part is to select your patients carefully. I don't know about you, but in my practice, the people that respond best, I grab onto them and every time they come back for something, I'll say, you know what? The PRP worked great for your Achilles tendon. I have a suspicion it's going to work great for your tennis elbow. On the flip side, the people who don't respond to anything, they don't respond to physio, they don't respond to cortisone, they don't respond to medications, I have a very high suspicion they're not going to respond to PRP either. The next thing is do PRP at the right time. And I've got all this listed out in those documents at sportsmedus.com / PRP webinar, that 81-page PDF. So what I mean by that is I had a lady in 2 months ago, and she had a really bad, really nasty Achilles tendon pain that was bugging her for 2 years. And I said, well, we can do PRP now. Do you have any reasons not to do PRP? She said, well, I want to get out and enjoy like a trip with my grandchildren. I said, great, do the trip with your grandchildren, come back. And she said, well, I've got my curling season because I'm up in Canada. Curling starts in late September, believe it or not. She said, I've got my curling season in late September. I'm like, perfect. We've got to time the PRP so that it doesn't interfere with your trip with your grandchild, and it doesn't, and then you heal up enough so you can enjoy the beginning of your curling season. The next thing is you've got to prepare people for pain. I've had people do PRP. I've done PRP for people And more than a dozen times, they've come back and told me it was the most painful experience of their life. And I've had that happen enough. I started preparing for it and preparing patients mentally for it and preparing them with, some medications to help blunt the pain so they don't wind up in an emergency room. I've had some of my students say, I did a PRP, the patient went to the emergency room that night because the pain was so bad. And I think that's a disservice to the patient and to the emergency room. The next thing is, and finally, it's an ultrasound guided workshop or webinar we're going to run today here. So we got to put the PRP, the right amount of PRP in the right spot. And so there's your protocol. Start with more than 10 billion platelets, select patients carefully, do PRP at the right time, prepare for the pain, and put the right amount of PRP in the right spot. Now, when I was in university, I remember reading this book by a self-help businessman named Stephen Covey. It was called The 7 Habits of Highly Effective People. And one of those habits was begin with the end in mind. So that's how we're going to start this webinar. We're going to start beginning with the end, and that's how do you do the injections? So in the course and that course I'll send you over to later if you want more information, I've recorded 25 different injections. Over the past 3 years, I've recorded 170 different injections of myself in clinic. And in this PRP course online, it contains 25 injection demonstrations with picture in picture, with a camera on me, a camera on the ultrasound, zoomed in with sort of annotations on it, so you can actually see how to do these injections. So many times I've Googled how to do the injections, and the quality of the instructional videos I found wasn't high enough and wasn't slow enough for me to be able to understand what was happening. And so I said, you know what? For my courses, I'm just going to have to create my own. So I've done that. And some of those are in the free course, and I'll link over to that later. So protocol part number 5, put the right amount of PRP in the right spot. Let's look at rotator cuff. So it seems easy, right? Find the tear and do the injection. No, it's not. This is a workbook that I came up with for my courses covering how to treat people with cortisone, hyaluronic acid, because I'm in Canada and I have actually a soft tissue hyaluronic acid that's made by a company in France. This product is available most places in Europe, South America. I'm not sure about Asia, but so we can do soft tissue HA. But we're here for PRP today. There's a bit about prolotherapy, which is dextrose injections, and then PRP. So this workbook that you can download by going to sportsmedus.com/PRP webinar has 25 of these workbooks or these recipe sheets, which includes what I think is important at the timing of PRP. So someone comes in with a supraspinatus tear, and I'll go through this slowly for this one so you understand the format, and then we'll go through it quickly for all the other body parts we'll cover today. So I don't usually do PRP injections within the first 6 weeks of pain. And let's be honest, I don't usually do it within the first 26 weeks of pain. Usually by the time people see me, they've had rotator cuff pain for months and months or years and years. So I think the optimal candidate has no tears, just tendinosis. But I'll show you a paper that's actually later in this webinar that actually flipped my thinking on this. And I'm actually going to go back and revise this slide based on this paper I found recently. I think a suboptimal candidate has a visual analog scale of greater than 7 out of 10 with normal activities of daily living. So again, this is where I think you got to select your patients right. If a patient comes in with a 7 out of 10 pain drinking their coffee, I do not think PRP is the right way to treat that patient at that time in their disease and their suffering. So I personally use a little bit of anesthetic. There's a lot of chatter out there. There's a lot of evidence to say that if you use lidocaine or bupivacaine, it really harms the effectiveness of stem cells and also of platelets. And I fully agree with that. Yet at the same time, I've got a living, breathing patient. This is not a laboratory animal. This is a living, breathing patient who is fearful. They're suffering. And if I do PRP without any anesthetic, I don't think for most people it's the right way to do it. So through expert consensus with an organization, a stem cell organization I teach with, a lot of us started using either ropivacaine 0.2%, which has been shown not to be nearly as harmful to platelets or to stem cell function. The other way to do it is if you can't get your hands on ropivacaine, get yourself a 10 milliliter normal saline syringe, sterile normal saline syringe for injection, not those ones for washing. Sterile normal saline for injection, push out 1 milliliter of that normal saline, and then pull up into the syringe 1 milliliter of lidocaine 1%. So now you've taken your lidocaine 1% and diluted it 10 times. Now you've got 0.1% lidocaine. So that's just enough to inject into the skin, inject into the needle track, and inject the tiniest bit into your target. It also helps, I genuinely think 0.1% does take the edge off the pain that from the subsequent PRP injection, but at a very minimum, it's helping the patient with placebo. It's also helping you make sure you can get your needle into the right spot without using, this valuable liquid gold, this PRP you've made up. So for supraspinatus tendon, I want to make sure you get I almost always use yellow PRP or the leukocyte poor stuff. There's yellow and red, and I'll get to that in a minute. And I want to aim for at least 5 billion platelets. I'll put my PRP in a 5 milliliter syringe. Now, a 5 milliliter syringe does go up to 6 milliliters. If you take your 5 mil syringes, you'll pull and you'll actually see that it goes beyond 5. If you take a 10, it goes beyond 10. And so 3 milliliters is a common amount I'll inject, but I want to make sure I've got 5 or 6 milliliters of PRP ready just in case, I don't know, something happens. I put it in the wrong spot. I inject it and it flows mostly into the bursa, and I want to go back to the tendon later. I follow up with a quick dash disability of the arm, shoulder, and hand every 4 weeks for 6 times because I want to capture how people do over half a year. That night, I will either give them tramadol plus acetaminophen or codeine plus acetaminophen for pain relief. Because again, a lot of people tell me this was a highly provocative procedure that really gave them a horrible night's sleep. So I will not immobilize people unless I'm really worried about high pain, and then I will sling them for 2 to 3 days. I'll return them to activities of daily living, usually the next day, unless I put them in a sling, return to therapy at 1 week, return to sport. I discuss with their therapist first. And I'll repeat the PRP treatment at 6, 8, or 10 weeks. So I just put 8 weeks in here. Now, I want to ask you, I want you to reflect. Anytime you've seen PRP webinar or PRP courses, have you ever seen, and put in the chat, have you ever seen a workbook like this? And please, if you have not ever seen a workbook like this, put it in the no section, like in the chat, put no, I haven't, no, I haven't, no, I haven't. I think I've got the only workbook, recipe book for cortisone, HA, prolotherapy, PRP in the world, and I'm giving it to you free at sportsmedus.com/PRP webinar for you because I want to give you tools that you can take away from this webinar and use rather than just sort of an entertaining 45-minute chat. All right, so how do I do the injection? So this is a big, strong guy. So of course, we've all done ultrasound before. So we see on the shoulder here, here's the skin. This thickness is this man's really thick deltoid. He's a big law enforcement officer, goes to the gym all the time. Somebody has made something similar. Oh, Renny Enriquez, amazing. Thank you so much. I'm glad if you haven't seen this before, again, go ahead and download it because I think it's one of the few out there. But Renee, I'm glad you've done something similar. Great minds think alike. That's amazing. So what we see here, of course, is the peribursal fat. The subacromial bursa is barely visible. There's really no fluid in the lumen of the bursa. Here's the superficial aspect of the supraspinatus. There's a small defect here, so let's have a peek at the injection. Now, I know I said I almost always use yellow PRP. I use yellow PRP. If I think the fluid's going to get into the joint, I sometimes back away from the red PRP and use yellow. Now, this gentleman does not have a full thickness tear with extension into the joint. So this is one of those situations.
So that's supraspinatus, but I also always want to get biceps as well.
So
could you
This was a gentleman I also knew. I've done PRP on him a few times before, and I know he can tolerate almost anything. So therefore, the red PRP I think is more provocative, more irritating. So I knew he'd be able to tolerate this well. Now, why do I always want to do long head of biceps for a supraspinatus injury? I have a very strong suspicion. Let me tell you a little story. I had a guy one time who ruptured, he'd used anabolic steroids in university, and he ruptured both his patellar tendons and high-grade tears of both his quad tendons. He came into me and said, "Hey, can you do PRP into my patellar tendons that have been surgically, sewn back together because I just want to help the healing." So I took my 22 gauge needle and I put it with PRP into his repaired patellar tendon, and I'm injecting it without any anesthetic. And I said, "I'm sorry about this pain." And he said, "What pain?" "I feel no pain at all." Like literally, his reconstructed patellar tendons were insensate. They felt nothing. So I started thinking, I'm wondering if people have a high grade tear of things, is it actually the torn tissue that's painful or is it the tissue adjacent to it? And I'm probably not the only one who's had this thought. So when I see somebody with a supraspinatus tear, so let's say the supraspinatus in the middle, I'll also touch their infraspinatus. And lo and behold, very frequently the infraspinatus, which is not torn, is even more painful than the torn supra. I'll also then touch the biceps. And lo and behold, the biceps, well, it's painful in almost everybody, but lots of times the pain comes from sort of not only the torn tissue, but the adjacent structures that are on high alert that have a higher mechanical load. So I make sure that when I've got a tear, I want to treat the adjacent structures as.
Please turn your palm up a little bit more. Good, thank you.
So I turn the palm up. There's my long head of biceps just here. With PRP, I want to make sure I get right into it.
Is that a familiar pain that you're feeling there? Or is it just crummy? Okay.
So really important question there. I always say to people when I put the needle in, is that a familiar pain? Do you feel like that's a pain signal that you regularly get? Because I don't necessarily want to inject things if the only reason they hurt is because
so a lot of people will have a lot of pain in that biceps tendon. But when we got to it, he said, "Nah, that's kind of just crummy. It's not really where I feel my pain." So we will circle back and do the rest of the treatment deep into the supraspinatus tendon.
So as you can see, some of the fluids leaking out into the bursa, that's not a problem. I've had some
and you can see some of it's leaving the tendon, flowing into the bursa around the corner on the left-hand side of the screen. Totally normal. Nothing wrong with that. All right.
I want you to put in the chat if you have a thought. I want to put in the chat if you have a thought about PRP into the bursa. I personally have had maybe 10 people in my career. Let's say, I don't know, I'm going to pull out a number. Let's say I've done 300 or 400 PRPs to rotator cuff. I've had to put PRP subsequently, 2 weeks later or 3 weeks later into the bursa in maybe 10 of those 300 people. Put in the chat if you've had any similar experience where you've done PRP, 3-4 weeks goes by and the patient's still really painful with guarding and they're just in a ton of pain, and you bring them back and you use a small dose, 10 or 20 milligrams of triamcinolone or methylprednisolone into the bursa to calm them down. I've certainly had that experience. I don't know if it's because it gets in the bursa. I do not think that. Almost every single one of my supraspinatus PRPs gets PRP into the bursa, so I don't know what it is that does that. But just know that is a strategy. If the PRP creates too much of an inflammatory response, you can circle back and put a dash of an anti-inflammatory into the area 3 or 4 weeks later. So for tennis elbow, again, we're going to go through this quickly here. Maximum amount I inject is 4 milliliters, and that is a ton for tennis elbow. 2 or 2.5 is a common amount. So let's look at what it.
Again, this is dilute anesthetic. It's 1 milliliter, 1% lidocaine, and 9 milliliters normal saline. There's some evidence to say that lidocaine in very strong quantities might decrease the effectiveness of the PRP. However, in 0.1%, expert opinion says it's not a factor at all, and it certainly takes the edge off the treatment when you do that. So you really want to sort of think about this as a sponge you want to fill up. So fill up every little bit of the sponge. We also want to do sort of a needle tenotomy where we're passing the needle back and forth several times. You see that little injury open up there. I like to go in short axis as well, so we can see the full tendon in short axis.
I really like the short axis view. So here's our common extensor tendon in short axis. I want to make sure I pass the needle to each of these sort of quadrants of the tendon to make sure I'm covering it broadly. I think about the tendon like a sponge and I want to fill up everything. So just like the rotator cuff, not only do I want to hit the injured area, but I want to hit the spots adjacent the injured area. Same thing with common extensor tendon. So sports hernia, that's how it's known in North America. It's a silly term that came about. There's a story that John Jacobson, a radiologist, told at one of his lectures one time. But I'm going to show you the adductor longus tendon. This is not included in the paid course or the free course online, but I just wanted to show you. So the image will get better here. This is a,
All right.
little camera
So first
malfunction.
question.
So first question I find out is the patient painful at the adductor longus tendon distally down here? Very frequently, my patients with sports hernia or adductor longus injuries will point maybe 10, 15 centimeters distal to the pubic ramus as a site of their pain. But for this gentleman, I'm needling it here. There's the tendon within the muscle. And he said, that's not it. So I slid more proximally. And now I'm going to needle. Now I will needle up more proximally. It's quite high, actually. And as you can see, he's holding back his penis and his scrotum so we can do the treatment. And here's my adductor longus tendon. I'm coming in out of plane. And so with the probe, you'll just see the needle dancing. And he says, that's getting closer. Yep. Am I too low? Yeah, a little too low. Okay, so now I know to go up a little high. Oh, actually, sorry, I was coming in plane in this example. So now I know to go up a little bit higher. And he's about to say, yep, that's the spot. So I encourage you, getting closer. Yeah, great. So I encourage you to continue searching with your needle to make sure you're in the right spot rather than assuming you know the right spot. So for this injection, I'll then grab do a little bit of anesthetic. I'll then grab in this case, I used yellow PRP and I'm coming in this case, out of plane to do the adductor longus tendon. And then for the remainder of his treatment, then we moved the drape downwards and we approached from proximal. So the rectus abdominis aponeurosis as it approaches the sort of the anterior pubic plate, and we got all that stuff. This gentleman wound up so why did I do this? This gentleman, selection with these is incredibly difficult in my experience. I'll just play this again.
So first question.
Selection with these is incredibly difficult in my experience. This gentleman actually had high-grade labrum tears in his hip joint. He was in the queue to see a surgeon. Surgery was actually expected, but we wanted to see what we could do in the meantime prior to surgery to see if we could reduce some of his myofascial and his tendinous pain so he could continue exercising and be active. So this is one of those ones where choose the right patient at the right time. I did not promise the world to this man. I said, look, I think you're going to need a hip surgery. We'll do what we can to help your myofascial pains, and we'll do our best. So moving on to knee joint now. For knee joint, I used to inject sort of 4 or 5 milliliters. No longer. The knee can handle so much. I'm commonly injecting 8 milliliters. Why? Because I want to get every single platelet I can and get it into the knee. I've injected as much as 15 or 20 milliliters in a knee that frequently swells. I know it can hold 30, 40, 50 milliliters of fluid. So there's no reason I can't put 8 or 15 milliliters of fluid
left-hand side, we've got our femur
into a knee.
Under the quadriceps tendon is a small black line which represents the fluid in the suprapatellar recess. But if we just move our knee up to the final position, and you're good at that, well done. We can see some fluid pop out just here. Okay, and if we go, and you can just relax that ankle, there we go. And if we all we have to do is pop our PRP into that spot and it flows underneath the kneecap into the rest of the knee joint. We'll go back to full screen by double clicking the top button. That's how I set up my preferences. I then spin into short axis on the femur.
So as you see, this is the Clarius. So if you got a Clarius,
there's the fluid
And here's the lateral
You've got a
aspect of the core.
Clarius or a handheld that you're using, put it in the chat. I'm really curious how many people are using handhelds. So I use handhelds because so many students in my courses use handhelds, and I said, look, I got to get familiar with these. So in my main sports medicine clinic, we've got five sonocyte machines, 40 or 50,000 US dollars. However, for many of the videos, I also shoot them with handhelds so people can see what's V-scan. Yeah, the V-scan there, I think is a good one. Claris is good, I think. Butterfly. Um, Little heavy to be using a needle too. I know I've got size 8.5 hands, and so for me the Clarius is okay. But we've got students that have taken our courses that where they've got like a size 6 hand, and I just think the Clarius isn't right for them. So all I'm demonstrating here is how I do knee injection into the suprapatellar bursa. In our courses, we call it the suprapatellar recess of the knee joint. Now, of course, in some cases where people have a ton of scar tissue in the suprapatellar bursa, I've actually seen adhesions in the suprapatellar bursa and there's no fluid, there's no way in. So in those cases, what I'll do, this was for some educational videos I shot for Clarius. What I'm doing here is I'm going in plane from medial to lateral at the patellofemoral joint. So essentially, I'm just kind of poking underneath the kneecap from the medial side. So that's sort of my get out of jail card. That's a reference to the game Monopoly that was popular when I was a kid. So that's a nice, easy way to be sure you are retropatellar with your injection. So this patient tolerated this well. There we go. There's my PRP in. ATFL for the ankle, the amount I'll use usually 1.5 milliliters for an ATFL. I want to make sure I'm using about 2.5 billion platelets. So again, the way you find the ATFL is you put your fibula in the center, rock your distal end of the probe flat. Your probe has to now be parallel with the bottom of the foot. Once it's parallel with the bottom of the foot, the ATFL pops out. So here's a little bit in the skin and down to the needle track. Now it's a 30 gauge 1-inch needle, so it's kind of hard to see. Then put the needle on my... So again, you're seeing in all these videos, I'm using a small amount of dilute anesthetic to make sure I can get to the right target, get a needle, get some practice with it, and also confirm with the patient, yes, that's their painful spot before I put PRP in there. For the ATFL, you doing okay? Okay. So here's fibula up top. I'm doing all the places where the ATFL attaches. So usually about half a milliliter or a milliliter at each entasis. Come a little more distally. So selecting the right patient. So why did I do this for this patient? This is a woman who had had an inversion sprain. She'd had I think it was like a posterior talar fracture. It was a really weird injury. And a year and a half later, she was still having ankle pains. We tried low dose cortisone and it helped for a month. And then we moved on to the PRP. We had to do it 2 or 3 times and she got improvement, but then she'd come back and we did low dose cortisone again. So I have been to so many courses where people say, look, this treatment will work 90% of the time, or they'll say, learn this technique and it'll work 95% of the time. I'm here to be honest with you and say, if you select your patients right, I think PRP can be very, very helpful in 2/3 of the cases, but I do not abandon all the other treatments. I do not abandon physio. I do not abandon cortisone. I do not think it's 1 or 2 injections and done for the rest of their life. I just want to be open and honest with you. My experience as a sports medicine doctor. So type in the chat if you have a similar experience where PRP does not work 95%. If you're getting 95% success with PRP, you know a lot more about it than I do, or patient selection than I do. So let me know what sort of success you think PRP has in your hands. Is it 50%, 70%, 10%? Let me know. So that was protocol part number 5. Now there's tons. Somebody just asked me which platform I use, and I use 5 different platforms in my clinic, simply because some patients come in and say, I want this one, or I had this one done in another city. Some of the doctors I work with say I'm really particular with a gel tube for teenagers, but I really, really like the Arthrex Angel system for seniors or whatever.
So this all this sort of cheat sheet here is in the free online course that I can send you to later. However, again, you can get at sportsmedus.com/PRP webinar like an 80-page accompaniment to this. So there's going to be some questions later. So I always liked it when my professors would give me a sneak peek at what might be on the exam. So this was a paper looking at tendinopathy by Miller et al. And so if you want to find it, you can Google that PMID. We're recording this. You can go back and look at it later. They looked at a bunch of different PRP for different tendinopathy. And essentially, they summarized that the lateral epicondyle tendinopathy had the most comparisons in those papers and was most effective, was most responsive to PRP, followed by rotator cuff and Achilles. So lateral elbow, rotator cuff, and then Achilles. So in case that question comes up on the exam later, on the quiz later, tennis elbow is your correct answer. So next one was a meta-analysis done in 2016, I think was updated in 2023. PMID is there. And what they looked at was RCTs for knee arthritis, and they found that at 12 months post-injection, PRP was associated with significantly better pain relief than HA. So in case this question comes up on the quiz later, PRP provides sustained pain relief for up to 12 months in knee OA patients, according to the meta-analysis by Dye. And this one actually changed my practice. So earlier I said I think the optimal patients for PRP for rotator cuff are patients with only tendinosis, not tears. This paper completely changed my opinion on it. Or sorry, has been a big influence on my thinking. So what they did was, again, they draw 90 mils of blood, and that's important for a very good reason. If you draw 12 milliliters of blood, you are not having enough platelets to get a good enough effect on the majority of your patients. So what they did was they followed lots of different things, including global improvement. And they found that the people who responded best, this purple line up here, had greater than 50% partial thickness tearing, whereas the people that only had tendinitis or tendinopathy had actually the lowest response rate, which was completely backwards from what I thought. So, and I actually had one the other day. This lady who had like a 5 years of a chronic retracted supraspinatus tear, and I did a relatively lower dose of PRP because I thought she was going to be super sensitive to it. She called me up. She said she was in agony for 5 days. So I prepared her for it, gave her codeine or tramadol, and then she said at 3 weeks now, her shoulder feels the best it has in years. So these are the little anecdotes that always make me, it's always nice to hear on a webinar. So reminder, if this comes up on a quiz later, the patients with greater than 50% partial thickness tears had improvement. So we're going to slide past forward a bunch of slides that are in my online course and just get to how do you get 10 billion platelets? Well, it's simple math, and I'll rip through this quickly. So this was a paper published in Arthroscopy that did a great job of showing a beautiful schematic of what's in whole blood. Oops, it looks like I'm not sharing anymore, so I'm going to hit share again. Okay, you should be able to see it again. Okay, I'm not sure what happened there, but there's always funny things that happen with webinars. Okay, so here's a paper that shows you what it looks like with a whole blood. There's PRP systems that concentrate all the platelets right in this central layer next to the leukocytes, but also next to the erythrocytes. So we would call this a leukocyte-rich PRP. And despite the fact that leukocytes are white, supposed to be, um, by the time you grab all these platelets, you also wind up getting some of the red cells. Hence, this white blood cell rich PRP is actually red. It's sort of counterintuitive, but hopefully that explanation is simple and effective. And then there's other systems that essentially do not concentrate the platelets nearly as much. So we've got a dilute PRP, and you can get away by taking a bunch of platelets, but a lot of water, a lot of the plasma, but you don't get nearly as many leukocytes or erythrocytes. So we call this leukocyte poor. So this is yellow. So just a reminder, there's the leukocyte rich winds up getting mixed in with a lot of other cells. The leukocyte poor is not so mixed in with other cells. Okay, So what are we trying to make? Well, we're trying to make PRP that works. Well, how do you know that works? Well, you got to try it on your patient. If it doesn't work, you got to try a different recipe. So is there any recipe that seems to work for everybody? Well, gosh, no. That's just not realistic. So, how about we look at some of the evidence? So, this was a paper by a PRP expert named Peter Everts, and there's some excellent clinicians and researchers who were also signatories onto this, including Don Buford and Jeffrey Peng. And what they did was they looked at all the different, there's many, many different things, and they wanted to try to figure out how, was there anything in the papers that said angiogenesis occurred at a high rate and tissue repair occurred at a high rate? And for all these papers, the answer was many billion, 3, 4, 5, 10 billion platelets. So how do you count how many platelets you get? So what they did was, again, all these papers that had low platelet doses, 1 billion, 2 billion platelets, wound up having no significant outcomes. However, the papers that looked at higher doses, total platelets injected into the body part, 3, 4, 5, 8, 10, by and large had more significant outcomes. So that's what the plot looks like. How do I get 5 or 10 billion platelets? So it's simple math. If we know that the platelet range for humans is between 150,000 and 450,000 per microliter, per milliliter, you add three zeros. So instead of 150,000, it'd be 150 million per milliliter. So 150 milliliters. So, but I don't like difficult mathematics. So we're simply going to say, let's imagine 200,000 per microliter. That's 200 million per milliliter, or zero point 0.2 billion per milliliter. So if I hate math, that goes pretty fast for me. That's why I had to put it over 10 slides. So you take 1 milliliter of whole blood, let's say you'll get 0.2 billion. So if you want to get 2 billion, so if you want to get 2 billion, you would simply take 10 milliliters of blood. If you want to get more, you see the math there. So how do we get these numbers? Well, the answer is you draw a lot of blood. This would give you zero point 0.2 and so on and so on and so on and so on. So there's a lot of docs out there that say, look, if you're drawing less than 50 milliliters of whole blood for any PRP, you're not starting with anywhere near enough. And if you want to treat somebody with 10 billion platelets, you have to draw 100 or more milliliters of blood. So remember that rotator cuff paper that looked at really good success and all those different things? They drew 90 milliliters of blood, which means that they started with a lot more platelets than that. I can't do the math. Oh, yeah, I can. And they draw three of these. So they started their spin for their PRP with 18 billion platelets. They probably finished their spin with maybe 9 billion platelets. You're never going to be able to capture all. So if you draw 10 billion platelets, that does not mean you're treating your patient with 10 billion platelets. Your most yields, real world yields where you test it with a hematology analyzer, I've got a hematology analyzer. I can test what I'm putting in my patient. If you've got a hematology analyzer, type it into the chat. I'm really curious. It seems to me like maybe one in 200 or 1 in 300 docs has a hematology analyzer, PRP docs, which means that very few do. And I think it's, if you can afford it, if you can pass that cost on to your patient, it's an amazing way to actually see inside that blood tube and see what you're getting. 50 to 75% yields are common. Lots of the companies will tell you 90%, 95% yields, and I do not see that in my practice. If you see super high yields in your practice by counting, let me know, and I want to know what kits you're using. So it's very frequent that you'll start with maybe 10 billion platelets, but you're only going to be able to capture 5 billion or 7.5 billion if you're lucky to treat your patient. But again, so let's say 50 milliliters and about half of it's your PRP. So I can't put 20 milliliters, 25 milliliters into somebody's rotator cuff. So you have to be able to concentrate that super, super well. So anyways, I just wanted to introduce that concept to you. There's no sense in spending too much time on it. we're going to move on to, I just want to convince you, try to convince you that if you can start drawing higher volumes of blood, you'll get a higher amount of medicine to give to your patient. And the evidence is mounting that that's a really good idea. All right, so looks like my screen sharing stopped again. Looks like every time I get out of the presentation, that happens. Okay, there we go. So you got to select your patients carefully. So this is in that sportsmedus.com/PRP webinar. I use this chart with every single one of my new patients. And they come in and say, I have a tendon tear and I thought I might need surgery. I'll say, excellent. Have you worked through these physical therapy modalities? A lot of them say, yes, I have. I didn't get anywhere. Have you tried cortisone? Well, yeah, I heard it's not healthy for tendons, so I want to try other things like surgery. I'll go, gosh, there's other things. There's like hyaluronic acid we can use, prolotherapy or PRP or stem cells. And they go, oh, I heard about stem cells. Oh my gosh, I didn't know it was so much money. Maybe I'm not going to do stem cells. So this really helps all the doctors that take my live courses and they're adding things to their practice. It helps them communicate with the patient. It's almost like a menu at a restaurant. And if you went into a restaurant you've never been to before, and the waiter asks you, "What do you want?" and you have no idea what the costs are, or like how much you're going to get, you're going to wind up confused and uncertain. So I really like this table for my patients. If any of you, which HA available is in the US, and for injections, for tendon injections, there isn't any, unfortunately. It's not FDA approved. If any of you have something like this that you use in your clinic, type it into the chat, because I think it's a super good idea to be able to show patients a menu. We've got a menu for tendon and ligament, joint, and cartilage, and I put those in that PDF that you can download at that website. So that's how I select my patients carefully. I make sure they understand all the options, the price of all the options, why we're doing this. We're doing the cortisone because it's the least expensive. I didn't say the cortisone was the best. Or we're doing the PRP because it's 20 times cheaper than stem cells. That's why we're doing PRP. So it's just a communication tool. So you got to do PRP at the right time. So when I started working at a physiotherapy clinic in my small town here, the physio said, "What do you want to see, and when do you want to see it?" And I'm like, "Gosh, if somebody dislocates their shoulder, they have no reason to see me. However, I might want to do a low or high dose cortisone if they're not getting anywhere from physio, and then I may do PRP, prolo, or surgery later on." Whereas if they think they have a frozen shoulder, I want to see them before physio. I do not want you wasting 4 to 8 weeks with physiotherapy. You've got a locked shoulder. So this is where I think you have to select your patients right, but also get your timing right. So I'm not going to do rotator cuff tear PRP before they do a bit of physio. I'm not going to do it before I offer them at least a low dose cortisone. So that's available to you if you think that can help you in your practice. Incidence of DVT and injects PRP. Oh, we can get to that after. Great question. Prepare for the pain. All right, so this is perhaps the biggest one. PRP, you're rare to get a disappointed patient if they know that there's no insurance coverage and it might take 3 sessions. Heat and redness, you're not allowed to use Advil. If there's a possible infection, which is very rare because PRP is used to treat cutaneous dermatologic non-healing ulcers. So it's very rare to get an infection. But I treat people with a moderate pain flare-up by giving them 10 tablets of codeine. And if I think it's going to be a serious 911, sort of like go to the emergency room type flare, I'll give them Percocet. So the other things that I think you can benefit from, this was the treatment card, and this is the rationale for every single one of these. So, for example, buy the prescribed painkillers because I've had a lot of patients in a lot of pain on night one. How about apply ice? It's just for comfort. So not only is there a treatment card that you can download at that website, but there's also sort of why is this even on my list? So I'm going to go to show you some other injections that you can find in both the free course and the paid course, because that's why we came for all these protocols. But again, I wanted to introduce you to some of the injections. I'm going to start sharing again. I wanted to introduce you to some of the injections, and I wanted to introduce you to the recipe book. I wanted to introduce you to the fact that you need a lot of platelets, the fact that you need to select your patients carefully. You need to prepare for the pain, and so on and so on. So in the online course, there's subacromial bursa, supraspinatus tendon. We've got glenohumeral joint, common extensor tendon, first CMC joint, hip joint, greater trochanteric bursa, gluteus medius tendon. Oh, this is a gentleman who tore his quadricep tendon. I was treating his quadriceps tendon, and then 3 weeks later, he said he felt something snap in his butt. So then he had a gluteus medius tendon tear. We've got SI joint. Oh, that's one of my colleagues. He didn't get a good tan on his butt, apparently.
Hi there.
Medial collateral ligament of the knee,
Hey, Dr.
joint itself, the quadriceps
Now,
tendon, patellar tendons,
tibial
ankle joint ligaments, plantar fascia. So there's a ton of Achilles tendon, of course. There's a ton of reason. Oh, this one's a good one. This is a surgical rep who was a really tough guy. He'd run Ironmans. But gosh, okay, I want you to see, can you see his head popping up? That's points during the treatment where he was in sort of agony. So now I don't say that gladly. I say that to show you what sort of reactions your patients can get. Sometimes they'll do fine. Here he even puts the pillow over his head because he's in so much pain. So I think these are valuable learning tools that can help you see. You can come inside the treatment room with me to see what the patient experiences and how to handle it when the patient's sort of thrashing about in pain. So, anyways, hope that's been helpful. I'm going to jump back to the very beginning and show you uh, how to find the online course. So just a reminder that companion for the companion for the webinar was available at the first website, and then learn.sportsmed.com. Learn.sportsmedus.com is where you can find the free PRP course and the other paid course if you're interested. So I think the webinar was scheduled for 45 minutes, Tiffany. So I think we've got some questions and then question and answer. So I'll
Yes,
let you sort of take over moderation
yes.
from there.
Well, first of all, thank you so much for a wonderful presentation, Dr. Johnson. And we do have, Dr. Johnson has prepared some quiz questions for you. So I'm going to launch those and please answer them. And then we'll go get into our Q&A portion of the webinar.
So Tiffany, while people are answering those, there's a couple of questions, and I go back to 1018 in the chat. Blake Randall said something like, "I think the PRP goes into the subacromial bursa when you're doing a supraspinatus tendon. The PRP goes into the subacromial bursa no matter what." I think I totally agree with you, Blake. Next question is Renee Enriquez. What's the response rate for PRP with sports hernia? I think the response rate for sports hernia is all over the map. I think if you give patients a 50, I think if you can tell your patients, I think if we've diagnosed this correctly, and this is not your hip joint, and this is not an ilioinguinal nerve problem or a L2 or L3 radicular pain, all those caveats there. If this is actually truly a sports hernia, I'm going to give you a 50% chance of 50% pain reduction with 2 treatments of PRP. So again, that is a lot of statistics for a patient to take in. And so maybe you can simply say, there's a lot of things at play. I think we can help your pain, and we'll figure it out within 1 or 2 treatments. So I don't know how to answer it any more honestly with my patients. I think I'm not the I think sometimes I get a little too statistical with my patients. If anybody's got a better way of communicating success, type it into the chat because I'm happy to learn. Um, which
All
PRP
right.
platform? 1027, Manish Shah. And Tiffany, if you got other questions, jump in.
Yeah,
Otherwise,
I'm
I'll
just
just
going
keep
to end
going.
the poll right now so that our participants can see the results for the quiz. And I'm sharing them now so you see how you did on that quiz.
Okay, so I'll keep chatting here.
Yeah, go ahead. You can go through the questions in the comments, and then we'll go through the Q&A box in just a few.
Oh, for
I
sure.
am going to share now a learning score question that is going to stay up throughout the portion of the webinar. So take your time answering those.
Okay, I'll go through what's in the chat and then I'll go to the
Yeah,
Q&A
let's go
box.
through it. Yep.
Yeah, I'd forgotten the Q&A box exists. Okay.
Yeah, no, we'll do that
Um,
next.
okay, perfect. 1020, 1020. Which PRP? 1027. Manish asks, which PRP platform do you use? Again, in that sort of download, in that free course there, you'll see lots of different ones. I use 5 different ones. I don't want to name names, but I have like gel tubes. I have 20 mil kits. I've got 40 mil kits. I've got 60 mil kits. I've got 100 mil kits. And I've got a hematology analyzer to test everything. So, my advice for you is if you're getting started, start with something inexpensive that is not a financial burden to you. Use gel tubes. It's a great way to get started, but you've got to know 12 mil or 20 mil gel tubes do not get enough platelets to treat the vast majority of your patients. So, I just want you to know that there are limitations, but it's a great way to get started. That's how I got started. That's how most of us get started. Okay. Um, what's the incidence of deep venous thrombosis and PRP injections due to activation of platelets from Michael Shortall? I would say, great question. I would type that into Chat GPT and find out what the answer is. But I would say that as long as you're not injecting in a vein, that's not an issue.
Right.
Acute shoulder dislocation, a mature patient. Oh, excellent. So Christopher Job was just talking about how to choose the timing for patients. Peritendinous lidocation before intratendinous injection. So Christopher Job, absolutely. I use a dilute anesthetic around the tendon and into the tendon. I've tried it where I've just gone peritendinous. And I do not think peritendinous injection is adequate anesthesia for an intratendinous injection. I think if you try it several different ways on several different patients, you'll be able to get a gestalt for it, but I don't think it's adequate. In pain sensitive patients, I don't think it's adequate. In pain insensitive patients, I don't think you need anything. What do I think about PRF? So platelet rich fibrin. PRF is a product that makes a gel. And there's companies out there that are selling PRF kits that I think are lower cost than PRP kits. I want you to be very clear. Platelet rich fibrin matrix is a gel that's like it's not injectable through a 25 gauge needle. So platelet rich fibrin that dentists use or surgeons would use or um, dermatologists or plastic surgeons would use is very different than what we're injecting into a biceps tendon or something. Uh, okay. Any additional information for in-season for out-of-season athletes? Oh, Dylan, you read my mind. So I've got a ton of data available, a ton of coaching available in the paid course to help you through that. Let me show you what that looks like, and then we'll get to the Q&A. While I'm looking for this for
Yes.
Dylan, Tiffany, can you start reading the Q&A?
Yes, I can. And then I do want to mention that anything that Dr. Johnson shares throughout this webinar, we will send it in the follow-up email with the recording as well. So you have all the links and all the documents. And I do want to thank all of you for answering our learning score question. This helps us to plan the next sessions and receive feedback directly from you. We're now moving into the Q&A portion of the webinar. We have received quite a few great questions, as you've already heard in the comments and in the Q&A box. So let's begin. The first question, Dr. Johnson, are you providing nerve blocks before the PRP procedures to reduce pain?
That's a great question from Blake, and I'll answer that in a second after I answer the question from Dylan. So, Dylan and everybody else on the webinar, I think it's really important. Again, right patient, right time. So, physical workers, if they have normal work versus flexible work versus off work, I treat them all differently. This is available in the paid course, but I just want to give you the concept for non-athletes or retired patients, and there's no time pressure. I treat them differently than if there is time pressure. So just so you know, absolutely, I treat these differently. Okay. How about next question? So nerve blocks. Um,
Yes.
I am not doing nerve blocks for most people. My scope of practice is primary care sports medicine. So what that means is I am not a physiatrist. I am not an anesthesiologist. I want to simply give a simple case from the medical legal literature that showed up in Canada a while ago. There was a doc that did a finger laceration repair by doing a median nerve block. Patient had no problem during the procedure. 3 days later, wound up developing incredible pain, wound up going on to develop complex regional pain syndrome, complained, sued the doctor, and the judge found that the standard of care would have been a ring block. And had the doctor done the ring block, the patient would not have developed CRPS. So I'm not saying you shouldn't do nerve blocks. I'm just saying there are cautionary tales out there about doing nerve blocks prior to a simple injection or simple procedure. And that's why I do not teach doing nerve blocks in my courses. However, if you're experienced and skilled at nerve blocks and that's inside your scope of practice, I think that's a great way to help with anesthesia.
Thank
Next
you.
question. Next
Yeah,
question
the
was,
next question. Oh, did you want to read it, Dr.
oh,
Johnson?
sure. Can
Do you see it?
PRP be
Okay.
used for posterior neck muscles, splenius, for example? I think that PRP can be used for anything. However, I would never start someone's journey uh, with posterior neck pain by doing PRP. I would start them with obviously stretching, strengthening, dry needling, wet needling with normal saline, wet needling with lidocaine, wet needling with bupivacaine, wet needling with some other stuff before I would touch PRP. And almost always, when I've got a chronic neck pain patient over the age of 40, I feel like I've got to treat their cervical facet joints rather than just the muscles. That's my personal preference.
Thank you. The next
Um,
question.
Incidence of DVT and PRP injections. Again, I'd probably have to type it into Chat GPT. I've never heard of anybody who's ever done a PRP injection that's made its way back to me. Let's say a knee or a hip or anything. The patient's gone on to develop a DVT specifically because of that PRP injection. So I don't think it's a huge thing.
Dr.
Thoughts on
Johnson, real quick, somebody had a question about the nerve block in the comments, if we wanted to circle back there, before we went to another question.
Oh, sure.
Um,
So if I use a nerve block, how do I get feedback from the patient about the location of their pain? Yeah. So Manish asked a good question. So if you do a nerve block ahead of time, what I think is what you do is you place a needle without any anesthetic. So let's say you're doing rotator cuff, and you're planning on doing a suprascapular nerve block to try to reduce the pain from the rotator cuff PRP. Before you even touch the nerve block, you would take a needle, touch the different spots on their rotator cuff, figure out where they're sore, plan your procedure, and then proceed with the nerve block, or then proceed with the intratendinous dilute lidocaine or the ropivacaine 0.2%.
all
Thoughts
right.
on preventative dose of antibiotics? I think that antibiotics prior to PRP is not at all a standard of care. I would say in those cases where you think about doing antibiotics. So, for example, a patient with cellulitis, well, you shouldn't, cellulitis in the ankle, and you're going to do a knee injection. I would just defer the PRP. I just wouldn't do it. But whether you're doing cortisone injection or PRP injection, prophylactic antibiotics just are not part of a normal orthopedic or physiatry or anesthesiology or primary care sports medicine practice. But really good question because we want to be safe. We don't want to hurt people. Know if I use a linear or a curve for shoulder injection. In my courses, I teach people. So people come to my courses and say, "Can I get away with having a linear Clarius only, or a linear handheld only, or whatever?" And I say, or I want to buy a $20,000 machine and the linear is 8,000 and the curved is an additional 8,000. Can I get away with just the linear? First thing is there are some ultrasound machine companies that have a 5 centimeter long linear, and there are other companies that have a 3.8 centimeter linear. So the 5 centimeter linear can get you an awful lot more than the 3.8. Second thing is some companies have the ability to do a beam widening on the linear probe, and all of a sudden now it's almost like a pseudo curved. Sonosite just recently added that to their software. GE's had it for ages. So the third thing is the size of the patient. I think below 80 kilograms, you can do a hip joint and a shoulder joint with linear probe on almost everyone who walks in the door. Over 80 kilograms, there are many cases where you're going to have to use a curve. So to answer that, I use linear below 80 kilograms, curved above 80 kilograms. And does it work for shoulder pain and sonographer work-related injuries? Fabulous question. I think PRP works great if you've got a rotator cuff tear due to your work. But if it's just muscular tension, I'd probably suggest maybe getting a different chair and going for a massage.
Great. Great questions. And it looks like that wraps up our Q&A session for today. We have no more questions in the comments and in the Q&A box. And so that wraps up our session for today. Thank you so much to our presenter, Dr. Frank Johnson. A recording of this webinar will be made available on the POCUS.org website in approximately 1 week, and you will receive a link via email. Thank you for attending our webinar today, and we look forward to seeing you on our future webinars. Take care.
Thanks for attending, everybody. Hope it was helpful.